Welcome to the presentation of my behavioral health theory project. In this presentation, we are going to look at altering cholesterol levels in women with coronary artery disease and the impact that increasing exercise can have. In this presentation, you will receive an overview of coronary artery disease, the impact of this condition in women, and the importance of exercise as an intervention. We will also look at theories that have been applied to this research area, as well as current intervention options. The presentation will then conclude with a proposal for a new intervention based upon my research. Coronary artery disease is also known as cardiovascular disease, and you'll often see it abbreviated as CAD. CAD is characterized by atherosclerosis. This is the process in which plaque made from calcium, fat, and cholesterol builds up in blood vessels and eventually leads to the thickening and narrowing of the vessel walls. It is the buildup of plaque in the blood vessels that often leads to heart attacks. The American Heart Association estimates that 15 million U.S. adults have coronary artery disease, and the CDC states that about 610,000 Americans, both men and women, will die from CAD annually. Symptoms of this condition typically do not present until a heart event, such as a heart attack, and often include angina, fatigue, shortness of breath, and abnormal heartbeat. Muris, Rosen, Everett, and Russo stated that there are two kinds of risk factors, modifiable and non-modifiable. Modifiable risk factors include things such as age, heredity, including family history, race and ethnicity, and gender. Non-modifiable risk factors include lifestyle choices such as smoking and sedentary lifestyle, health conditions such as high blood pressure, abnormal blood sugar, elevated cholesterol, and being overweight or obese. Along with the two types of risk factors, there are other factors that contribute to the development of CAD, such as stress, insufficient sleep, alcohol abuse, poor diet, and nutrition. As we learned in class, before we can change a behavior, one of the things we must first understand is the determinants of the behavior. Social determinants are the conditions in the environment where we work, live, learn, play, and worship. A few examples of social determinants are income, education, occupation, availability of transportation, and social support. When beginning an exercise program, income can be an important determinant. Exercise equipment can be expensive to purchase initially, and for some, a gym membership can be a waste of income or time. Occupation can also play a role in the success of an exercise program. Those with more sedentary jobs, such as desk jobs, may have a harder time adopting an exercise program as their jobs don't allow for much in the way of movement. However, those with more active job roles may at least get exercise in the form of walking during their daily routine. For those who do opt for a gym membership or to join an exercise group, availability of transportation can also be important when trying to determine how to get to the gym or to the meeting place for a group. Availability for transportation can also be applied to how easily the equipment or exercise routine can travel if needed. Social support is also crucial for this type of intervention as exercise is more fun with a buddy. Having social support is important when attempting to make a behavior change as it aids in the development of self-efficacy. There are currently over 166 million women in the United States. Of those women, about 5.8%, or roughly 9 million American women, have coronary artery disease. A study conducted by the American Heart Association found that 43% of women were unaware that CAD was the #1 killer of women, killing 10 times more women annually than breast cancer. Heart conditions tend to affect more men than women, and for this reason, women are often overlooked as a population for research for these conditions. However, this could be due to women tending to develop heart conditions later in life than men do, typically 7 to 10 years later. Of women with heart conditions, Black, Latina, and Southern Asian women have higher risk than Caucasian women, up to 69%, for developing these conditions. This is due to higher incidences of high blood pressure, obesity, physical inactivity, diabetes, and metabolic syndrome, all risk factors in the worsening and initial development of heart problems like coronary artery disease. When a person has a heart condition, there are two kinds of cholesterol that are important to pay attention to: low-density lipoprotein, LDL, or bad cholesterol, and high-density lipoprotein, HDL, or good cholesterol. The major carrier of cholesterol in the blood is LDL cholesterol. These two forms of cholesterol play equally important roles when one has a heart condition. The lower the LDL level, the lower the risk of heart attack or stroke. Inversely, the higher the HDL level, the lower the risk of heart disease. According to Gilanov and Neeson, 20% of our cholesterol comes from diet. This is what makes it difficult to reduce cholesterol solely through diet interventions. According to the 2018 cholesterol guidelines for heart health, it is recommended that those with pre-existing heart conditions, such as CAD, have a LDL level of less than 100 milligrams per deciliter, and that high-risk patients, such as those with diabetes or recent heart events, aim for an LDL level of less than 70 milligrams per deciliter. Studies have found that aerobic exercise can raise HDL, good cholesterol levels, by 10%, with the degree of HDL increasing proportionally to the amount of aerobic exercise performed. The U.S. Department of Health and Human Services, Office of Disease Prevention and Health Promotion, published the Physical Activity Guidelines for Americans, second edition. This recently reestablished the guidelines for at least 150 minutes per week of moderate intensity aerobic activity. While exercise is important for everyone, it is especially important for those with coronary artery disease. Regular exercise can help in a number of ways. It reduces symptoms, mortality, and can prevent disease progression. Despite these and other documented benefits, only 19% of women meet the physical guidelines as reported by the 2018 National Health Interview Survey. Over the course of my research, I found several studies that had applied a variety of theories and individual constructs. These theories are the health belief model and the trans-theoretical model of change. The constructs that were used for evaluation most often are self-efficacy, outcome expectations, perceived self-efficacy, barrier self-efficacy, and task self-efficacy. Over the course of the next few slides, we will look at the theories individually, but we'll only discuss the individual constructs as required. The Health Belief Model, or HBM, states that a change in belief precedes a change in behavior. In other words, before we can change a behavior, we must first change the belief that acts as the foundation for that behavior. With regards to altering cholesterol through exercise, we must first alter the belief that one can lower their cholesterol through exercise. This can be done by first altering one's self-efficacy. For those with heart conditions, they must feel that it is not only possible that they can change their cholesterol levels through exercise, but that they can successfully change their cholesterol levels through exercise, that the benefits are worthwhile, and that any barriers that they might encounter will not inhibit their success. For those with heart conditions, beginning an exercise program, whether at home or through cardiac rehabilitation, is important. But specifically for those in cardiac rehabilitation, it is important to be able to apply the knowledge gained and exercises learned during the program to daily life once the program has finished. For those completing a home program, making sure that they are utilizing the right kinds of exercises are important. The health belief model looks at how likely one is to perform an action, in this case an exercise program. For many, they may feel that adding an exercise program into their daily routine will take too long, that the equipment that they need is not available or accessible, and in some cases, that joining a gym to have access to equipment would be too costly. The benefits of exercise lowering their cholesterol levels, and thereby reducing the risk of future cardiac events, can act as a benefit. The analysis of whether there is more benefit or more cost will vary according to person. The possibility of worsening condition or of recurrent cardiac events is the perceived threat. Combined, these two components form the likelihood of action, either leading to the starting or maintaining of an exercise program, or to the decision not to exercise. Another model useful in analyzing this behavior change is the trans-theoretical, or TTM model, also known as the stages of change model. This model reviews behavior change as a process and addresses the concept of relapse, the act of going backwards. It acknowledges that relapse may happen at almost any stage. This is something often seen when attempting to adopt an exercise program. Following this theory, those with CAD may be presented with information from either primary care or a cardiologist that engaging in an exercise plan would be beneficial, and some statistics and reasons of why it would be beneficial and how they could start, placing them in pre-contemplation. They may then look into their daily schedule, costs of necessary equipment, or gym memberships that have the needed equipment, contemplation. They may then begin to plan to fit exercise into their daily life and form an exercise routine or plan, preparation. Once they have determined that exercise can fit into their schedule, that they have access to the equipment that they need, and have a plan of action, then they can begin the intervention, action. Once they have begun exercising and continue to exercise, they move into the final stage of maintenance. Currently, there are three main interventions utilized to try to alter cholesterol levels. These interventions are diet, exercise programs, both home-based or cardiac rehab, and medication therapy. While diet does have an important role to play in altering LDL and HDL cholesterol levels, it is not effective alone. Medication therapy involves statins, including Lipitor and Crestor, or injectable medications such as Praluent and Repatha. While medications can be useful, they are not always preferable. An exercise program can be particularly useful when combined with diet, but can also be useful on its own. My proposed intervention is to focus on both the individual and community levels. While diet and exercise both have individual benefits, I believe that together they would be the best method for altering cholesterol levels. The diet should be low in saturated and trans fats. Both of these fats raise LDL, bad cholesterol levels, and lower HDL, good cholesterol levels. Soluble fiber is also important, as these foods prevent the digestive tract from absorbing cholesterol. There is also some evidence that for those with CAD, a diet high in omega-3 fatty acids can be beneficial. While omega-3 fatty acids won't lower LDL levels, there is some evidence that they may raise HDL levels. As discussed in previous slides, exercise is important, and by doing an hour of aerobic exercise 3 days a week, one with CAD could meet the exercise guidelines of 150 minutes per week. As discussed on previous slides, the health belief model and the trans-theoretical model are best for this type of intervention. The constructs of stimulus control and reinforcement management are two important constructs in the trans-theoretical model. Having control of situations and other causes which trigger problem behaviors, as well as the ability to reward oneself or being rewarded by others for making changes, are important, as both of these elements play critical roles in the development of self-efficacy. If one suffers from low self-efficacy, the chance of relapse or failure increases. The TTM also explains how behavior change works, in that changing a behavior is rarely a linear process marked as a finite event, but rather as a cycle of process. Utilizing a behavioral intervention, both diet and exercise, based on the TTM and HBM theories, those with CAD and other heart conditions have a better chance of lowering their LDL cholesterol, raising their HDL cholesterol, and preventing the worsening of heart conditions and recurrent cardiac events. What you'll see now are the references I've I've used to put together my slides. Thank you.